Hello, my name is Dr. Michael Miao. I'm a partner of the Desert Orthopedic Center in Las Vegas, Nevada, and the Director of Sports Medicine in the Department of Orthopedic Surgery at the UNLV School of Medicine. At the time of the production of this video, we are in our third year of the residency, and teaching the exam has revealed to me that there is a wide interpretation of what the various tests are and how they are performed. The video will present the physical examination that I have used in my 21 years of practice. Its purpose is to aid medical trainees in understanding the various elements of the physical examination, its implementation, and a suggested pattern of flow that is concise and comprehensive in nature. While I recognize that there are a great many examination techniques that have been described, this exam does not attempt to incorporate every one. The intent is to have a reasonably complete exam that will capture most diagnoses commonly encountered in the clinical setting. In my residency training, I learned more about thinking how to approach problems and perform surgeries. In my fellowship training, I realized I didn't fully understand how to evaluate a patient clinically. Part of my mission was to learn to perform a complete and concise orthopedic physical examination that would give me the opportunity to diagnose most conditions, regardless of the complexity. In my now 22 years of practice, I have been teaching this examination to medical and physician assistant students, family and internal medicine residents, and more recently orthopedic residents at UNLV. Thank you to my assistants Tiffany Moreno, Certified Medical Assistant, and Abby Fink, Certified Physician's Assistant, for their assistance in producing this video. The video presented involves the basic elements of the physical examination that I use. There are certainly more examination maneuvers that you can employ to provide a deeper investigation of the clinical issue. There are some elements of this examination that are beyond the ability of certain patients to accomplish. Using this framework, make judgments of what you and your patient can use of this examination pattern to generate clinical information. The intent of this examination pattern is to provide a concise and comprehensive framework of information that the clinician can use in a reliably repetitive fashion from patient to patient. Keeping a format helps to organize one's thought processes in formulating a running differential diagnosis as the exam progresses. In the reasonably agile patient, this examination can be accomplished in 1 to 2 minutes. For the primary care clinician, it is hoped that this helps to streamline your assessment of the musculoskeletal complaint in consideration of the multi-organ system world. This is not the expected physical examination for the acutely traumatized patient. Inspection, palpation, and if available, radiographs would be more appropriate in the setting of acute trauma. When I enter the exam room, I am immediately taking note of the presence or absence of wheelchairs, walkers, canes, splints, braces, or any other assistive device. Are there any bandages or wounds obviously displayed? Is the patient in a wheelchair or sitting comfortably in the exam room chair? Is the patient already sitting on the exam table? Ideally, the patient is sitting on a chair that I can see their posture and movements or lack thereof. I will ask the patient to stand and assess their ability to move with or without assistance. Ease of movement. If they are able to stand, then I assess their axial and rotational alignment. If possible, look at their foot posture as well. If possible, have the patient walk directly towards you and look at, again, ease of motion, limp, gait rhythm, etc. If possible, have the patient stand on one leg at a time to assess pelvic and hip control, balance, and strength. You can, if your clinical suspicion points to it, instruct the patient to squat, duck walk, or perform any other provocative maneuvers at this time. Make sure you are in a position to assist them if they lose their balance. Have the patient sit on the examination table and look at their movement and ease of stepping up and maneuvering their body position to sit. Do the legs hang naturally to gravity, or are the hip and femur creating an angular position? Is the tibial tubercle slightly or far lateral to the midline of the patella? You can at this time measure for the tubercle sulcus angle. Is the knee obviously swollen? If you're clinically suspecting a lumbar referred issue or neurologic issue, I find it convenient to do a neurologic exam in this position. Sitting straight leg raise, dermatome sensory exam, deep tendon reflexes of the patella and Achilles, with Babinski and Clonus testing can be done at this time. More typically, I do my muscle testing exam for the hip flexors, quadriceps, and hamstrings at this time. I can test ankle and foot muscle strength as well. The next phase is the supine exam. I start at the feet and look again at alignment and hip rotation, looking at the foot external rotation position. I check the dorsalis pedis and posterior tibialis pulses. I can do a neurologic exam in this position as an alternative. I support the heels and check heel heights for flexion contracture as well as recurvatum at the knee. I'll also check for pitting edema at the leg as well. I now step alongside the knee and palpate both knees for an effusion and soft tissue swelling. Palpate the medial and lateral facets, retinaculum if suspicious. Palpate the patella, quadriceps tendon, and patella tendon. Extend to the muscle above and tubercle below. Compression load the patella. Perform a quadriceps inhibition test. If the patient doesn't understand to fire the quadriceps, then have the patient slightly lift the foot off the table. Have the patient lift the leg fully off the table in the extension position to prove that the extensor mechanism is intact, not if you suspect a patella fracture or tubercle fracture. If intact, have the patient resist against manual load to test strength. Flex the knee and measure flexion range of motion. At this point, I test the joint above, in this case the lumbar and hip areas, for referred pain or proximal issues that can create knee symptoms. I perform a straight leg raise and a bowstring test, then perform hip range of motion in flexion, internal rotation, and external rotation. I then do a provocative flexion internal rotation stress and an abduction external rotation stress of the hip articulation. If necessary, I will then do a complete hip exam at this point. If not, then I do a flexion McMurray test, then proceed to the 90-degree exam. During the 90-degree exam, I generally sit on or next to the patient's foot to stabilize it. I reduce the tibia anteriorly to test the posterior drawer. If you do not reduce the tibia, you may miss the posterior drawer. Remember, there is a 1 centimeter step off on the anterior tibia normally. Then do the anterior drawer. I do a posterolateral and a posterior medial rotational test at this time. I find a lot of missed corner injuries this way in second opinions. Palpate the non-tender side first if applicable. For the medial side, I palpate the medial joint line, tibial plateau, femoral condyle, MCL, pes, and adductor. For the lateral side, I palpate the lateral joint line, tibial plateau, femoral condyle, LCL, and IT band. Posteriorly, I palpate the gastrocs bilaterally and the hamstrings bilaterally. Transition to the 30-degree exam. Perform a Lockman test, MCL and LCL stability tests at 30 and 0 degrees, and a patella apprehension. In my experience with KT1000 arthrometry, I prefer to do this part of the exam with a support or my knee under the thigh. I transfer my hand from the thigh to the anterior joint for the Lockman test, or the medial and lateral joint for the MCL and LCL test to actually feel the joint motion or separation during testing. I feel I can reasonably approximate these motions in some degree of millimeters of translation and motion. As always, it is best to compare the other knee in the exam. If I have concerns, quite often I do a lateral exam. With a patient on the side, I have the leg elevated against resistance to test gluteal strength. I then check for hip mobility and stiffness by extending the hip back. If the quadriceps is tight, the knee will extend here. I then perform an Ober test to see if the IT band is tight as well. In this position, it is easy to extend the exam up and posteriorly to complete the hip, SI joint, and lumbar exams. If further concern warrants, you can also have the patient move into the prone position to palpate the hamstring and gastric soleus complex more thoroughly and check the dial test in 30 and 70 degrees of knee flexion for rotational stability. We will now look at some videos demonstrating the physical examination. The first video will show the sit to stand transition, the standing exam, and the transition to the sitting on the exam table.
And go ahead.
Sitting to standing, walking, seagull length stance, comparison to the other side, and then sitting down up onto the table. The next video will show the optional neurologic exam, including dermatomes L1 through S2, deep tendon reflexes for the patella and Achilles, Babinski test, and clonus. Dermatomes L1 through 3 on the anterior thigh, L4, L5, S1, S2, and up. Deep tendon reflexes for the patella, the Achilles, Babinski, clonus. The next video shows the standard sitting exam in terms of muscle testing of the hip flexor, quadriceps, and the hamstrings. Muscle testing of the hip flexor, contralateral side, quadriceps, hamstrings, and the contralateral quadriceps and hamstrings. Next is a lengthy video showing the supine exam, including dorsalis, pedis, and posterior tibialis pulses, heel height, pitting edema, knee effusion, swelling, palpating the patella facets medially and laterally, quadriceps tendon, patella tendon, compression of the patella, quad inhibition of the patella, testing the extensor mechanism, strength exam, range of motion in flexion, straight legs for the lumbar spine, bowstring exam, hip range of motion in flexion, internal rotation, and external rotation, flexion internal rotation stress, abduction external rotation stress, flexion McMurray, and transitioning to the 90-degree exam, including reducing the tibia, posterior drawer, anterior drawer, posterolateral corner, posterior medial corner, medial joint line palpation with MCL, pes, hamstring, and adductor, lateral joint palpation with LCL and IT band, and the posterior palpation of the gastric soleus and hamstrings. Dorsalis pedis, posterior tibialis, pitting edema, heel height exam, checking effusion, medial facet, lateral facet, quadriceps tendon, patella tendon, compression, quad inhibition, extensor mechanism, strength, range of motion, measuring flexion, measuring the contralateral knee inflection, straight leg raise, bowstring stress, hip range of motion inflection, internal rotation, external rotation, flexion internal rotation stress, abduction external rotation stress, flexion McMurray, 90-degree exam, reduce the tibia, posterior drawer, anterior drawer, posterolateral, posterior medial, medial joint palpation joint line, MCL, pes, medial hamstring, adductor. We're going to switch to the other legs to see the lateral exam. Inflection, lateral joint, LCL, IT band, gastric soleus, hamstrings. The next video shows the 30-degree standard exam using the Lockman MCL and LCL 30 and 0-degree exam and patella apprehension. 90 to 30-degree transition, Lockman exam, supporting the thigh, valgus and varus stresses at 30 and 0 degrees, 30-degree apprehension laterally and medially.
Okay. You want to do another one?
Next is the 30-degree exam using a thigh support.
Go.
The thigh support is placed underneath the distal thigh at the 30-degree exam. The fingers are placed on the anterior tibia, so that the anterior tibia is felt during the lockment. They are repositioned to the medial lateral sides of the joint line during the MCL-LC exam to look for separation of the joint line. The next video shows the examiner's thigh or knee placed underneath the distal thigh as the support, again freeing up the left hand or the thigh hand to measure or feel for displacement. This video shows the pivot shift in the extension position with a valgus pressure and flexing it to reduce the tibia relative to the femur. This is a normal exam. The patient then rolls into the lateral decubitus position. You can palpate the greater trochanter piriformis sciatic notch, SI joint, iliolumbar, and the iliotibial band.
Go.
Okay, take that.
This final video shows the lateral exam in terms of abduction strength, anterior hip motion or flexibility, and the Ober sign.
Go.
Okay, leg up. Leg down. Okay.
When learning physical examination techniques, it is important to repeat and rehearse these techniques so that you become comfortable and reliable with these techniques. Make sure you know what you're doing and why. What are you looking for? Make sure you ask as you go through each of these parts of the test, what am I looking for? What is my differential at this point? And allow the next part of the exam to keep modifying that differential so that at the end of the exam, after doing a history as well, you have a very good idea of what you are dealing with. Good luck. Thank you very much for watching this video. Take care.